Welcome back to the deep dive. We're here again to take some pretty complex stuff, unpack it, and really give you the core understanding. Or let's unpack this. Today, our mission is to explore these really profound and honestly often surprising connections between parts of your health you might not link together. We're talking about the temporomandibular joint, your TMJ, various kinds of headaches, and sleep disordered breathing. Yeah, you might be sitting there thinking, what does my jaw have to do with how I breathe when I'm asleep? Or why would this nagging headache point to something, way beyond my head? Well, that's exactly what we're aiming to figure out today.
And to set the stage for this deep dive, our sources are really quite something. We're pulling from expert professional manuals, deep research articles, and foundational texts. These are from a highly certified expert in craniofacial pain and dental sleep medicine. So the goal here is to show how these areas which seem separate are actually, well, deeply intertwined. Think of this as maybe a shortcut to understanding these complex conditions. And also how the cutting-edge diagnostics and treatments are really trying to restore whole body health, not just, patch up symptoms.
That's a remarkable connection right there. It really forces you to rethink how you even approach these things, doesn't it? Because, well, if your breathing is the root cause, then just treating the headache, it's kind of like painting over a crack in the wall, right? So many of us, our first thought is medication for a headache or maybe a simple night guard if our jaw hurts. But these sources you've looked into, they propose something pretty revolutionary about what might be really going on underneath. We'll start by emphasizing a core idea from our sources. The body is this integrated system. It's not just a collection of separate parts that happen to be in the same container. And this deep dive will keep coming back to this holistic view, showing how problems in one spot can, well, cascade and affect totally different areas.
Yeah, it's actually striking how well documented this link is, the comorbidity between TM dysfunction, headaches, sleep disorders. And yet, it often gets overlooked in, actual clinical practice. A really crucial insight from these sources is, and I'm quoting here, maintenance of an airway is the highest priority for survival. That really drives home the point, doesn't it? Breathing problems can genuinely be the primary driver for pain symptoms somewhere else entirely. It kind of redefines what we even think of as a pain problem.
And there's a stark observation in the sources that hits this exact issue. They express concern about, and again, quoting, thousands of oral appliances, night guards, are being produced and delivered without CBCT or other diagnostic testing, especially for airway.
Yeah.
That just sounds like putting a Band-Aid on something much deeper, doesn't it? It completely underscores how vital it is to get an accurate diagnosis before jumping into any kind of treatment.
Exactly. And when you connect this to the bigger picture, it means TM joint pain, well, it isn't always just a local thing in your jaw. It could actually start from somewhere seemingly unrelated, like maybe the sacral region of your spine.
Sure.
Or consider this. Chronic airway obstruction, difficulty breathing, can directly lead to things like forward head posture, hunching forward, which then can result in TMJ problems, TMJ pathology.
Yeah.
So understanding the whole body's anatomy, how everything interacts, it's just fundamental for getting the diagnosis right.
Okay, so with that foundation that the body's all connected, let's zoom in specifically on the TMJ itself. We tend to think of it as just, the jaw joint, but its functional anatomy is incredibly complex. The sources explain it's not just a simple hinge. It's this intricate system. It's got a specialized disc, various tissues, all allowing for really precise movements, which unfortunately also makes it really susceptible to imbalance and injury.
In this joint, it has some surprising connections anatomically. For instance, there's something called the discomalleolar ligament. It directly links the TMJ to the malleus bone. That's one of the tiny bones in your ear. So this helps explain how TMJ issues can actually contribute to middle ear symptoms or feelings of tension in the ear. A lot of patients experience that but might never connect it to their jaw. It really shows just how interconnected all these structures in our head and neck truly are.
So what actually causes the pain in this complex joint then? The sources mention common culprits, things like prolonged wide opening maybe at the dentist,
Yeah.
which can stretch or even tear ligaments, and clenching. Now, that point about clenching being more damaging than bruxing, than grinding, that feels a bit counterintuitive. Why is just clamping down worse than actual grinding? What's the mechanism there?
It really boils down to the constant, sustained compression. When you clench, you're basically stopping the natural movement of synovial fluid. That's like the joint's lubricant, right? Imagine squeezing a sponge completely dry and holding it. It essentially starves the joint surfaces. And that lack of lubrication and nourishment causes far more damage over time than, say, intermittent grinding. It's the lack of motion and that vital fluid exchange that makes clenching so insidious.
Ah, okay. That's a critical distinction. So it's not just about the force, it's the lack of lubrication and movement. Okay. This brings up another important question. What about malocclusion? A bad bite. For years, that was kind of the main suspect for TMJ problems, wasn't it?
It absolutely was. But the sources we looked at suggest it's actually more often a result of an underlying skeletal asymmetry. So this asymmetry leads to the joints getting overloaded and the nervous system getting irritated. Think about it. Patients who have what's called a skeletal class 2 malocclusion, where the upper jaw might be a bit constricted, the lower jaw set back, they have a higher tendency for TM dysfunction. So often, the bite issue is really a symptom of the underlying bone structure, not the root cause itself.
And here's another fascinating variable, one that often gets missed. Hormones. The sources explain how the hormone relaxin, which is more prevalent in females, can actually contribute to ligament laxity, meaning ligaments are stretchier. And this might be one reason why statistically more women end up seeking treatment for internal derangements of the TMJ compared to men. It's a biological factor, often outside our direct control, just highlighting the complexity.
And it's quite striking how many other contributing factors can be involved, really broadening our understanding. You have systemic diseases like rheumatoid arthritis, even certain viral infections can trigger or worsen TMJ problems. And it's not just medical conditions. Lifestyle, occupational things matter too. Think about musicians playing certain instruments like the clarinet that can cause the jaw joint to shift backward, or even just common habits like cradling your phone between your shoulder and ear. All these things repeated over time can definitely contribute to TMJ issues.
The sources also walk us through the stages of disc displacement, which is really key for understanding why acting early is important. So in stage 2, you might hear that clicking or popping sound when you move your jaw. That means the disc inside the joint is moving out of place, but then popping back in. That's displacement with reduction. But here's the critical takeaway from the sources. Getting intervention at this stage, often with something called an anterior repositioning appliance, is really crucial. Because if you don't, it can progress to more severe stages like stage 4 or V, where the disc doesn't go back into place. Those are the non-reducing stages. And that's characterized by limited movement, often pain, and potentially degenerative changes inside the joint itself. Treatment becomes much harder then, and sometimes less successful. Okay, and this leads us nicely into another absolutely crucial piece of this puzzle, the role of sleep. There's this powerful bidirectional relationship between sleep disturbances and chronic pain. They feed each other, and this is where it gets really interesting for a lot of us, because sleep can either be this amazing healer or, well, a huge disruptor.
The clinical consequences of untreated obstructive sleep apnea, OSA, are really significant. The sources lay this out very clearly. We're talking about an increased risk of motor vehicle accidents, poor job performance, depression, but also serious cardiovascular issues. Things like arrhythmias, irregular heartbeats. Up to 50% of OSA patients experience nocturnal arrhythmias. But what's truly alarming, and maybe less known, is that OSA has also been shown to contribute to a breakdown of the blood-brain barrier. That could potentially lead to actual brain injury over time. So this isn't just about feeling tired, it's potentially about your long-term brain health.
Wow. And that statistic you mentioned earlier, 51% of patients seeking treatment for OSA also show signs and symptoms of a TM disorder. And those prospective studies showing OSA symptoms often precede the TMD onset. That really just flips the script, doesn't it? It makes you seriously wonder how many people are maybe treating the wrong problem first. They're focused on the jaw pain when the real underlying issue is how they're breathing or not breathing at night.
Precisely. And what's fascinating here is how sleep bruxism, that clenching and grinding we talked about, often acts as a key mechanism of microtrauma to the TMJ. Sometimes it's actually the body's subconscious attempt to thrust the jaw forward, to open the airway during sleep. But, and this is a crucial warning from the sources, studies are now showing that common night guards, the ones people often get from their dentist, can actually worsen sleep breathing problems. This seems particularly true for maxillary appliances, ones that fit on the upper teeth if they increase the vertical dimension without also bringing the lower jaw forward, or if they have excessive plastic covering the palate. They can inadvertently make breathing harder at night. It's a critical point for anyone using or considering a night guard.
The sources also point to something else interesting, a high prevalence of nasal obstruction in patients who complain of orofacial pain. They explain how nasal valve compromise, or NVC, which is the most common type of nasal obstruction, shows a significant link with capsulitis, inflammation in the TMJ capsule. And get this, a 7 times increased risk of facial and cervical myositis, so muscle inflammation in the face and neck. It makes sense when you think about it, right? If you can't breathe well through your nose, you automatically become a mouth breather. And that can lead to fatigue in your jaw elevator muscles, the ones that close your jaw. And then, what happens? Reflexive clenching, as your body tries to stabilize everything.
And this raises an important question about, well, hidden links in our daily lives, things we might not even consider. The sources uncover a surprising connection between common medications and substances, things like SSRIs for depression, dopamine agonists, even methamphetamines, but also alcohol, nicotine, caffeine, and exacerbated bruxism, or sleep-disordered breathing, for example, heavy smokers. They're twice as likely to report bruxism. And even common prescriptions like Ambien for sleep or Lyrica and gabapentin for nerve pain are associated with bruxism. This just stresses the vital need for awareness, both from patients and the doctors prescribing these medications. It's a reminder that what we put into our bodies can have these far-reaching, sometimes unexpected effects on our sleep and our pain levels.
Okay, so we've talked about the physical structures, the TMJ, the airway, the huge impact of sleep. Now we need to tackle the nature of pain itself. Let's try and make these complex neurological ideas a bit more accessible. Our sources explain nociception first. That's basically the initial detection of a potentially harmful stimulus by your nerves. But, and this is crucial, they clarify that nociception is not the same thing as pain. Pain perception, they emphasize, absolutely requires the brain. It's the brain's interpretation of that incoming signal.
Exactly. And this leads us into something called central sensitization. This is where chronic pain input literally changes how your nervous system functions. Your body essentially becomes overly sensitive to pain signals. It leads to increased responsiveness in your central nervous system neurons. It leads to expanded receptive fields, meaning the pain can actually spread beyond the original site of injury. And it can cause allodynia. That's where you feel pain from a stimulus that isn't normally painful at all, like just a light touch on the skin. The sources even talk about silent nociceptors. These are nerve endings that normally don't fire, but they become active when there's inflammation, and they basically amplify your pain experience.
Digging a bit deeper into specific kinds of nerve-related pain, the sources discuss neuropathic pain. This results directly from damage to the nerves themselves. A classic example is trigeminal neuralgia. People describe these sudden electric shock-like bursts of excruciating facial pain. Sometimes it's thought that crosstalk between damaged neighboring nerve fibers contributes to this. They also explain neuromas. These are painful growths of nerve tissue that can form even after relatively minor trauma, and they can cause this continuous shooting pain long after an initial injury should have healed.
And connecting this back to the bigger picture, we can also see something called sympathetically maintained pain, or SMP. This is where your body's fight or flight system, the sympathetic nervous system, actually starts generating or worsening pain under certain pathological conditions. It gets inappropriately involved. A key clinical indicator, for example, of injury to the sympathetic nerves in the neck is Horner syndrome. That presents with a constricted pupil, a drooping eyelid, and a lack of sweating, all on the affected side of the face. It's a powerful, visible example of how your nervous system itself can directly drive a pain state.
So what does all this complex pain science mean when it comes to headaches? Well, the sources guide us through the usual classifications: migraine, tension type, cluster headaches, chronic daily headaches, and so on. But they also highlight something absolutely critical. Many headache conditions, even those diagnosed by specialists as primary headache disorders, might actually stem from those underlying skeletal asymmetries we talked about, or from connective tissue injuries, maybe in the neck or jaw. So the headache itself might just be a symptom, not the root disease, pushing us to look much deeper than just the head pain itself.
And what's fascinating here is learning to differentiate. The sources point out key features. In cluster headaches, for instance, the pain is famously described as excruciating, typically one-sided around the eye, and it comes with characteristic autonomic symptoms. Think tearing, a runny or stuffy nose on that side. Then there's the critical urgency, and the sources stresses, of investigating something called giant cell arteritis, or GCA. This is crucial for any new-onset headache in patients over 50. Why? Because GCA can progress really rapidly and carries a significant risk of blindness or even stroke if it's not caught and treated quickly. It emphasizes that some headaches are true medical emergencies.
Okay, so we've got this incredibly complex picture: interconnected jaw, airway, sleep, pain pathways, headaches. How on earth do clinicians accurately diagnose these tangled issues? Let's unpack the diagnostics.
Right, the sources really detail the evolution here. TMJ imaging has come a long way. Back in the 1970s, there was limited appreciation, maybe just listening to joint sounds. Dr. William Farrar did pioneering work there. But now we have sophisticated tech. Cone beam CT, or CBCT, is amazing for visualizing hard tissue's bone. It can reveal subtle osteoarthritic changes, bone spurs, flattening of the joint surfaces. And importantly, it gives precise one-to-one measurements of the airway space, which is critical. Then you have magnetic resonance imaging, MRI. That excels where CT doesn't visualizing soft tissues. So it shows the actual position of that articular disc, whether it's displaced, and it can show inflammation or fluid in the joint. And there was this really surprising finding from a study back in '96 by Tasaki and Westison. They found that only 18% of patients with TMJD symptoms had normally positioned discs on their MRI scans. Compare that to 80% of symptom-free volunteers having normally positioned discs. It just shows how common these internal derangements are, even if they aren't causing severe symptoms yet.
Wow, 18% versus 80%. That's stark. And beyond just looking at pictures, imaging, what about objective diagnostic tools, tools that measure function?
Absolutely. There's joint vibration analysis, or JVA. This technology essentially listens to the vibrations your jaw joint makes as it moves. It can accurately identify and differentiate between things like clicking or crepitation, that grinding sound pinpointing the underlying pathology through analyzing the vibration signature. It uses complex analysis like fast Fourier transform to get really detailed information. And then there's electromyography, EMG. This measures the electrical activity of your muscles, usually chewing muscles, in tiny units called microvolts. This gives clinicians an objective way to see if muscles are overworked or spasming before treatment, and then, crucially, to demonstrate if the treatment is actually working by showing improved muscle function afterwards. It's truly data-driven care, moving beyond just subjective reports of feeling better.
Okay, so JVA for joint sounds, EMG for muscles. What about specifically diagnosing those airway issues we talked about?
Right, there are specialized tools for that too. Rhinometry is one. It measures the cross-sectional area inside your nasal cavity. This helps identify where an obstruction might be. Is it soft tissue, like swollen turbinates, or is it a structural issue, like a deviated septum? And then there's pharyngometry. This assesses the space in your oral pharynx and hypopharynx, basically, the back of your throat. It helps determine how patent or open your airway is back there, and also its potential for collapsing during sleep, which is key for understanding OSA risk. These tools give objective numbers to guide treatment.
And for diagnosing sleep disorders themselves, the gold standard is still polysomnography, the overnight sleep study, right? Or sometimes home sleep tests, HSTs.
That's right. PSG is the most comprehensive, usually done in a lab. HSTs offer a convenient home-based option, though they capture less data. Our sources emphasize looking at key metrics like the apnea-hypopnea index, the AHI. That counts how many times per hour your breathing partially or fully stops, and its severity categories are important. Normal is generally considered less than 5 events per hour, mild is 5-15, moderate 15-30, and severe is over 30 events per hour. But here's a really crucial point the sources make. It's vital to actively review the raw data from the sleep study, and especially the hypnogram, that's the graph showing your sleep stages throughout the night. Don't just rely on the summary report or the AHI number alone. The raw data can reveal nuances about when events happen in what sleep stage and what body position that are critical for tailoring treatment effectively.
That makes sense getting into the nitty-gritty. Now, you mentioned something earlier, a diagnostic approach for structural injury. Motor nerve reflex testing. That sounded intriguing.
Yes, MNRT. This is based on the work of an orthopedic surgeon, Dr. John Back. It's quite fascinating. One key part is the light and dark test. It sounds simple. You test muscle strength, often shoulder muscles, under normal light, and then again when the ambient light is significantly reduced. Surprisingly, this can screen for conditions related to sympathetic nervous system overactivity, that fight or flight system being stuck on. It's sometimes called sympathetic reflex dystrophy. And here's the really amazing part. The sources mention that stabilizing the TMJ, even temporarily with something as simple as tongue blades between the teeth, can sometimes reverse a positive light and dark test result almost instantly. It just powerfully demonstrates how instability in your jaw joint can create this widespread neurological disturbance throughout your body. There's also another test mentioned, the P0 test, which looks at neurological reflexes related to your postural control.
Wow, the body's connections are just incredible. And finally, the sources also stress, quite rightly, the comprehensive nature of just the initial patient intake. It's not just about the physical exam. It includes getting a really detailed patient history and also using psychosocial metrics questionnaires like the PHQ-9 for screening depression symptoms and the GAD-7 for anxiety. This acknowledges the reality that chronic pain, especially, often involves this complex interplay between organic physical factors and psychogenic emotional factors. Getting the full picture is absolutely essential for truly holistic care. Okay, so once this incredibly thorough diagnosis is made, painting this whole interconnected picture, how do clinicians actually approach treatment? What are the pathways to healing?
Well, the sources present two core philosophies, really. There's the palliative approach, which is basically focused on reducing symptoms, managing the pain, making you more comfortable. And then there's the therapeutic approach. This is aimed at actually rehabilitating the injured structures, addressing the root cause, and restoring long-term stable orthopedic function. And for true lasting resolution, the sources strongly advocate for that therapeutic path. It's about finding lasting solutions, not just putting on temporary band-aids, even if it takes more effort initially.
That makes sense. So what does that therapeutic approach look like in practice? You mentioned appliances earlier.
Right, the primary appliance therapy detailed is the use of customized decompression orthotics. And these are not your generic boil and bite or simple flat plane night guards. They typically require separate, custom-made appliances for daytime and nighttime wear. Often, they need to be worn pretty much 247, maybe taking them out only for eating for an initial period of maybe 10 to 12 weeks. Their design is very specific. The goal is to gently decompress the TMJ, take pressure off the joint structures, and also, crucially, to prevent the lower jaw from sliding backward during sleep, which can worsen airway issues. The sources even mention a precise fitting technique called the sibilant phoneme registration technique. This uses your S sounds during speech to find the optimal therapeutic jaw position, ensuring the appliance works harmoniously with your natural function. And they really stress the critical role of using certified dental laboratories that specialize in fabricating these complex therapeutic appliances accurately.
Okay, and connecting this specific treatment back to sleep again, these mandibular advancement splints, or MAS, and oral appliance therapy, OAT, so they're shown to help with OSA, right? Improve those AHI scores.
Yes, absolutely. When properly designed and fitted for sleep apnea, these appliances that hold the lower jaw forward can be very effective in opening the airway and significantly improving OSA symptoms and AHI scores for many patients. They're a recognized treatment for mild to moderate OSA, and sometimes even severe OSA if CPAP isn't tolerated. However, and it bears repeating because it's so important, the sources reiterate that critical caution. Do not just prescribe or use generic night guards off the shelf or even simple custom ones without considering the airway. As we discussed, studies demonstrate some types can actually worsen sleep-disordered breathing, especially those that just prop the bite open vertically without also ensuring that mandibular protrusion, that forward movement of the lower jaw, or those with bulky palatal coverage. It's a crucial distinction between a therapeutic sleep appliance and a simple bruxism guard.
Got it. Beyond the appliances, what about other therapies? Are there adjunct treatments that help?
Definitely. The sources discuss some innovative adjunct therapies. One is low-level laser therapy, sometimes called photobiomodulation. They specifically mention using specialized medical lasers, like the MLS-MFI laser, which uses specific wavelengths, 808 and 905 nanometers. Studies cited showed it could reduce pain levels by about 50% for jaw joint pain and muscle trigger points. It's a non-invasive way to help manage pain and inflammation. And interestingly, they also touch on traditional Chinese medicine, specifically the acupressure point Li4, located in the web between the thumb and index finger. It's known as Higu. It's noted for helping with stress, facial pain, and headaches. Though they do include a specific precaution, it shouldn't be stimulated strongly during pregnancy. It shows a nice blend of modern tech and ancient wisdom being integrated.
And treatment isn't just about physical interventions, right? The sources strongly emphasize the holistic and lifestyle aspects too, especially diet.
Oh, absolutely. They dedicate significant attention to dietary changes. They even reference the historical work of Dr. Weston Price, who studied primitive diets back in the early 20th century. His work showed profound connections between traditional nutrient-dense diets and healthy craniofacial development. Strong jaws, wide palates, straight teeth. What's really groundbreaking here, as presented in the sources, is that diet isn't just about general wellness. It's foundational to the very structure of your face and jaw. And that structure directly impacts your breathing and your susceptibility to pain. They advocate for principles of what they call a deflame diet. This generally involves eliminating common inflammatory triggers like wheat and dairy, significantly reducing sugar intake, and prioritizing alkaline-forming foods. They suggest a ratio of about 25% protein to 75% vegetables. The idea is to counteract an acidic internal environment, which can impede healing and contribute to inflammation. So this isn't just about feeling a bit better, it's framed as actively disarming the inflammatory processes that can contribute to those skeletal asymmetries and chronic pain conditions we've been talking about. It's about creating an internal environment where genuine healing can actually take place.
That's a powerful perspective on food as medicine, or maybe food as foundational structure. What about medications? Are they part of the picture?
Yes, these sources discuss what they term rational pharmacotherapy. It's acknowledged that medications can play a role, especially in managing acute symptoms or specific types of pain. They cover various drug classes. NSAIDs like ibuprofen for inflammation, muscle relaxants for spasm, certain antidepressants, particularly tricyclics or TCAs, which can help with nerve pain and also improve sleep, anticonvulsants like gabapentin or Lyrica, specifically for neuropathic pain, and sometimes, judiciously, opioids for severe acute pain. But the emphasis is always on using them rationally. That means careful monitoring of liver and kidney function, being very aware of potential side effects, and crucially, checking for drug interactions, especially since these patients are often complex. And quite interestingly, they also briefly touch on the very real and often impactful placebo effect in patient care, acknowledging that belief and expectation can be powerful therapeutic allies as part of the overall healing process.
Okay. And one more critical piece you touched on earlier was posture. How does that fit into the treatment plan?
It's absolutely crucial. The sources highlight this link strongly, referencing the work of Professor Mariano Rocabato, a key figure in craniocervical principles. He explained how that forward head posture, head jutting forward, shoulder slumped, is actually interpreted by the brain, essentially, as the body falling over. It's an unstable position. This, in turn, triggers what he called a dystrophy alarm system in the body. Basically, a warning signal that something is fundamentally out of alignment and needs correction. The really good news here is that effective TMJ treatment, particularly the decompression orthotics we discussed, often leads to a significant measurable improvement in head posture. Studies mentioned in the sources show patients gaining back over 4 inches in proper head posture on average as their jaw and neck alignment normalizes. It's a visible, tangible shift towards better biomechanics and overall health.
4 inches. That's substantial. It really shows how correcting one area can ripple outwards.
Exactly. And that really leads to the concluding point on treatment from the sources, the paramount importance of an interdisciplinary team approach. This isn't usually a one-provider fix. It often means incorporating skilled physical therapy, particularly therapists trained in craniofacial and cervical issues, maybe involving physical medicine specialists, coordinating with ENTs for airway issues, sleep physicians. Collaborating effectively across disciplines is key to achieving the best quality of care and helping the patient reach what's termed maximum medical improvement, or MMI. That signifies the best possible outcome, ensuring comprehensive and hopefully lasting results. It really is about a coordinated team effort for the patient's well-being.
So after all this, what does it all mean for you listening right now? I think this deep dive has really revealed these profound, often quite surprising, and frankly undeniable connections between your jaw health, the way you breathe, your experience of pain, and just your overall well-being. It's definitely a complex tapestry, but it's one that absolutely can be understood and, more importantly, addressed.
And hopefully by understanding these intricate relationships, you feel more empowered. Empowered to look beyond just the isolated symptoms, the headache here, the jaw click there, empowered to maybe ask deeper questions, to seek out clinicians who look for root causes, and to pursue comprehensive rehabilitative care that aims for lasting health improvements. It really is about seeing the whole person, not just the site of the pain, and recognizing the body's incredible inherent capacity to heal when it's given the right conditions and the right support.
And maybe here's a final provocative thought for you to take away and consider. What if this persistent, maybe seemingly unrelated aches and pains, or perhaps even just those nagging feelings of fatigue or brain fog that you or someone you know experiences, what if they are actually silent signals? Signals from this incredibly complex system inside you that's desperately trying to optimize its most vital function, just breathing effectively. What deeper connections might your body be trying to tell you?